Hello and welcome to ID Talk, Answers from an Infectious Disease Expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of October 19th. Total cases in the United States per the CDC are just over 8.1 million cases, with, as of today, October 20th, as I'm recording this, 218,986 deaths in the United States. The American Academy of Pediatrics data, which it records from state health departments, has found, as of October 15th report, 741,891 total cases in pediatrics, which is 10.9% of the total cases of testing in this country. Pediatric testing of all tests accounts for 5 to 17% of the total tests sent. And of those tests, around 3.5 to a little over 14% are positive in pediatrics. Hospitalization rates, 1% to 3.6% of the total numbers of cases. That number is slowly going up. Mortality, thankfully, remains very low, registering anywhere from 0 up to just 0.27% of the total. That's nationally. Looking now specifically at Arizona, as of October 15th report, we have dropped down to number 7 in the country for our total attack rate, and we are just over 1,700 cases per 100,000. That compares to the national average of 986 cases per 100,000 children. And we are looking at 13.8% of our total cases, this is cumulative, are in pediatrics. Our testing rate is just over 14% of total tests sent are being sent in that birth through 20 years of age. And of the tests sent, just 14.1% are positive, equal numbers there. Hospitalization rates in Arizona, children, or again, birth through 20, are accounting for 2.5% of the total hospitalizations. And the mortality rate, in fact, the total number of deaths, has been down estimated to 9. We have been at 10 cumulative since January of 2020 when this first started, our recording that is. And so that's a good thing. It likely has to do with continued redefinition of what counts as a COVID-19 associated death. So that's where we're at. That actually brings up one of the questions that was submitted in the last several weeks, and that was, given the numbers I've just quoted, and that Arizona thankfully is experiencing much lower numbers than when we were number 1 in the world for some time, why are we still so much higher than other states? And this question, I think, was based on data from October 8th, at which point Arizona was number 5 in the country versus number 7, which is, again, just 2 more points dropped down in the most recent report. Why are we still so high when our numbers currently are looking good? I think the best explanation is that these are cumulative numbers, even though they're being expressed as a rate per 100,000. And because we weren't just high, we were super high with our numbers of diagnosed cases. It will take some time for other states to increase their numbers to drop us further from our number 1 position. So every week when this report is released, we are seeing a decrease in our standing, which is a good thing. We don't like being number 1 for this indication. It'd be nice to see it for good indications like education, healthcare delivery, resource delivery to those who need it. But at least we're getting there. So I think that's the best explanation. Quite honestly, where are we at? Pima County, where I'm currently at, is currently still experiencing low numbers with only a slight increase. The rest of the state, again, focusing on the cities or regions surrounding Phoenix and Yuma, is seeing a drift upwards again. And this is unfortunately what we've come to expect looking for the next 2 years. It is likely, even as we proceed into hopeful, successful vaccination and ongoing, we hope, use of social hygiene, masking, etc., that our numbers will be lower. But it is still expected that the United States and the world globally will experience peaks and valleys over the next 2 years of COVID-19. How high or how deep the peaks and valleys are really depends on how effective the social hygiene measures are and presumably how effective our vaccination and vaccination strategies may be. That remains to be seen. On the subject of vaccinations, where are we at, both sort of with the adult vaccines and for pediatrics as well? So I think we've all seen at least some of the media reports that the two messenger RNA vaccine products, those being produced by Moderna and also by Pfizer, though those continue to recruit cases, they're getting close to concluding their phase 3 trials. And Moderna actually, when last I reported, just had 2,000 recruits yet to go. Reports are, although this is not official, that they have nearly completed their phase 3 trial. Pfizer has a little bit further to go. Their target is a bit higher, 45,000. And also, as many of you saw, Pfizer has now actually announced that they'll be testing that messenger RNA vaccine on pediatric patients ages 12 years and older. Now, that was announced. I don't know where they're at in opening up the recruitment process, but in general, it takes about 3 to 4 months from time of starting the phase 3 recruits to get the numbers which they need. And then they're typically looking for a 2-month period after the end of recruitment to look for efficacy data and initial early safety data. Both vaccine trials, Moderna and Pfizer, as with all the others, will have a several-year washout period after recruitment to look for persistence of a seroprotective response and also on efficacy and, of course, safety of the vaccine. So one of the questions sent to us in the last several weeks is, when do we anticipate not only testing on the pediatric patients, but also getting results and then hopefully discovery of and release of a vaccine with some pediatric indication? Again, if we take today, October 20th is day 0, and it's likely that recruitment is starting in Pfizer right now. We're looking at least 6 months still before we might get indication to support an application to the FDA for the pediatric indication of the vaccine. In general, though, both vaccine products, Moderna and Pfizer, are anticipating going to the FDA with an application for approval sometime by mid to later November. That is the most recent data which has been released by media release. Proof is in the pudding. What is the safety data at the time? What is the efficacy data? But at least it looks like we may be given access to that through the FDA by the end of November. If approval is granted, and although it's a permissive target of 50% efficacy, yet the safety requirements and the efficacy requirements are still quite robust. The FDA, thankfully, is holding firm on this one. It is likely we will not see production of and release of doses of vaccine for the first responders until sometime in mid to later December. In anticipation of that, reports are that both companies' products are being manufactured, so the doses will be made available up in the millions and then distributed as per plan. Plans to guide how vaccines are released, if and or when approved, are also in the works. It is very likely that healthcare/first responders will be first in line. My hope, of course, is that they would include in that our teachers and other downstream high-risk individuals whose services to the community are so critical. So that's where we're at for the timing for the messenger RNA vaccines ×2. The next one to discuss is the Janssen Pharmaceuticals, the subsidiary of Johnson & Johnson, and that, to remind you, is the single-dose replication-efficient adenoviral vectored vaccine. That trial, unfortunately, just started to recruit and then was put on hold for unspecified safety reasons. And unfortunately, we don't have the media release to let us know exactly who, what, when, why, or where. But we are certainly hoping that an independent safety review board can look at that concern and come back to us with some further information. Similarly, AstraZeneca, which was the other adenovirus replication-efficient vectored vaccine, is still on hold in the United States due to that concern from a transverse myelitis patient or patients in the United Kingdom, although the trials in UK and other parts of Europe have been restarted for AstraZeneca. So that's kind of where we're at in terms of vaccines which are nearing safety testing and application for FDA approval in the States. My prediction is that we'll be hearing more from both Moderna and Pfizer in the next several weeks as they hopefully put together a packet and go to the FDA. So that is the update on vaccines. Some other questions, and these are having to do with clinical elements. One specific question has to do with adolescents with loss of sense of smell. That is absolutely the anosmia reported as one of the presenting clinical features. But this question goes further in saying that this practice or practitioner has had experience with a Hispanic adolescent who had clinical symptoms of COVID-19, but then also stated that everything smelled of garlic. This is a new one to me, and I certainly have heard of a fair amount of clinical presentations of adolescents, both patients that I myself have managed and also in communication with community providers. I'm not aware of unusual or strong scents or smells as being part of the presenting anosmia, which we're seeing in other COVID-19 patients. So this may be something new. If any and or others of you are encountering this, please let us know. There's no reason to not start to capture new data if something new is being emerging. And it may simply be that other parts of the world just attributed that to normal sense versus an adolescent that we know doesn't normally smell or smell garlic. Along those same lines, though, the association with unusual neurologic features and neuropsychiatric features continues to be demonstrated. We continue to receive scattered reports of Bell's palsy or other cranial nerve palsies. Certainly in the adult population, an association with Parkinsonism continues to be described and examined. And absolutely in those COVID-19 survivors, a much higher than expected rate of cognitive dysfunction, neuropsychiatric disorders, depression, anxiety, suicidal ideation, you name it. So that this is a very big deal in terms of neurotropism of the virus itself and then neuropsychiatric effects in actively infected and recently infected individuals. What about, or what do we know about long-term side effects of COVID-19, the post-COVID-19 syndrome as described? What is known is that this is a thing, and B, a big thing. It appears that upwards of 30 to 40% of COVID-19 survivors are describing some combination of symptoms or findings which, at least temporally, seem to be associated with their COVID-19 active infection. The array of symptoms expressed principally are anxiety and fatigue, closely followed or associated, of course, with depression. The cognitive dysfunction has more been seen in adults, but that simply may be that our pediatric patients are less good at expressing their confusion or even potentially dyslexia or dyslectic type appearances. So yes, the neuropsychiatric component of post-COVID-19 is very definitely being experienced. Of those in kids, the fatigue and loss of engagement in school, in family, and social life perhaps have been most prominent. Those are closely followed both in adults and in pediatrics/adolescents by exercise intolerance, deconditioning, loss of normal cardiac health. Certainly, our student athletes who've been affected have been noticing a major decrease in their performance. Many times that is the extent of their complaints, just that they don't feel as aerobically competent as they did prior to infection. Some of our patients, however, are specifically describing chest pain, palpitations, especially sort of the runner's stitch if they're being exercised aerobically. As per AAP recommendations and certainly supported by our pediatric cardiology colleagues, our student athletes who have symptomatic cardiopulmonary findings need to at least be evaluated by EKG, looking for evidence of left ventricular hypertrophy or even potentially dysrhythmias or blocks. And those patients who are symptomatic further at least should be considered for referral to a cardiologist for an echocardiogram, and some of those even deserve 24-hour Holter monitoring. So my suggestion to all of us is to be very cognizant of active symptoms, much as we would anyway when we're screening a student athlete for a return to sports. But any findings of palpitations, chest pain, dyspnea, chest tightness, anything like that, I think we should be very conservative in our approach and actively engage EKG and cardiologists in the further evaluation of those individuals. For all the others, I think we can anticipate ongoing fatigue and a very delayed return to normal functioning. And how long that lasts is anybody's best guess. There are, as you would imagine, multiple social network-based support systems springing up around the world, and there are many survivors who are describing 3 months plus of their post-COVID-19 fatigue. As always, how much of that is clinically based, how much of that is supratentorial? I guess I would suggest it doesn't really matter because the new pandemic now is in those post-COVID-19 survivors who have, for whatever reason, been deconditioned out of normal active functioning. Now's a good time this is not to us necessarily, but I think just to society as a whole, but to be engaging additional support systems, physical therapy, occupational therapy, certainly counseling, social support, psychological support. I think that this will be the anticipated next great need. What else clinically? Great question. Should we be advising patients with different blood types to take different precautions, or should we be treating them differently? This is in reference to continued emerging evidence about the risk seen in patients who are blood type A in terms of both risk of getting COVID-19 and potentially having a more severe outcome if they get COVID-19. As it appears, the genetic locus at which the ABO blood typing is located is close to another gene locus, which encodes expression of ACE2 receptor. So it makes sense, of course, that if one is A positive, there may be an active upregulation of ACE2 receptor coding and production, or perhaps a loss of inhibition or whatever the mechanism. It seems reasonable that there could be blood type specificity. And this actually has been demonstrated now in a recent large series which looked at genetic typing and correlated that with severity and onset of disease. So all that said, should we be treating our A or A positive patients any differently? I would suggest no, because once a patient has infection with SARS coronavirus 2, they are going to be as or at the same risk based on other comorbidities as anybody else, regardless of blood type. So somebody who's type O, for example, which seems to be the least likely to get infected with SARS-CoV-2 and the least likely to have severe disease if they're infected. But yet, if that same individual has cardiovascular disease and obesity and diabetes and asthma and everything else, I would suggest to all of us that they have similar or even higher risk than somebody who does not have the comorbidities. So perhaps our better screening needs to be presence or absence of comorbidities and use that as our principal intervention to assess risk. If we happen to have a clinical series of patients, then of course it'll be interesting to see how the blood type factors into hospitalization rates. Other than that, I think it's basically all hands on deck regardless of who is what type of blood type. Let's see if there are other questions here. I think that's the vaccines, that's the loss of sense of smell. Final questions then have to do with the experience as schools around the state start to open. And indeed, I think we are probably all living in communities that have experienced at least one high school that has experienced some degree of shutdown or some degree of cases. In fact, just in Tucson, we had 2 additional schools in 2 separate districts have to react to positive high school students. What's interesting is that we're not seeing a huge number of students in K through 5 or even middle school that are turning positive and causing a school shutdown or case contact investigation. They do exist, and certainly earlier on, even prior to the active discussion of school openings, there were several that had gone to a hybrid model, and there were middle schoolers and even 5th graders, a couple that were found to be positive. I think that is what we can anticipate, is that as we get into more and more hybrid models and in-person school systems, we will see a wider age range of students that are testing positive. I suspect that there may be more children in the elementary and middle school populations that are truly positive, but they're not coming to medical attention because they are more likely than a high schooler to be asymptomatic. Again, this all has to do with age-based expression of the ACE2 receptor for the virus. The younger one is, the less likely to have symptomatic disease, and therefore the less likely to trigger that case finding and, of course, the media release. So stay tuned on that one, only if by doing a universal screening of all of our school children. Now, I'm not proposing we do that. That is resource heavy with very limited positive benefit. But if we were to do that from a research perspective, then we would likely see similar numbers of younger and older children turning positive. But for right now, it is principally the high schoolers who are encountering this and the ones who are triggering further case findings and causing media releases. So that is the news as I see it so far. As always, thank you for listening to ID Talk. Arizona AA members can submit questions for future episodes and also input about what you're experiencing, please, to COVID, COVID, at azaap.org for more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit aap.org. Until then, stay safe, stay sane, stay passionate. Thanks a bunch, folks.